Good afternoon again. We started a little late this morning, but we caught up and we're going to start on time this afternoon, so we'll have the full time to interact and interchange. I don't know about you, but I had a very interesting and exciting morning listening, and I hope you got a sense of the lens I was talking about, the public health ethics lens, just looking at the same issues from a different context and trying to assess what you heard from a different frame, not the facts per se, though they are critically important. But what are the facts? Who are the stakeholders? What do we do? And what are the consequences if we do nothing? That's a framework that I hope you're able to use as we continue. What are the facts? Who are the stakeholders? What do we do? And what are the consequences if we do nothing? This afternoon's session really embraces that framework. What do we do? And from my context, we got to get it right. We must get it right. And I know my time in public health, I didn't hear words like right and wrong. I heard words like, it's statistically correct. Is it valid? Is it reliable? But is it right? What does right mean? And from whose context and whose right are we talking about? So the speakers were outstanding, and you were equally as provocative in not asking the same old public health questions. New questions, a new framework. And this afternoon will be equally as exciting. And the speakers, the three of us, had a conference call the other day to talk about this session because we want to get it right. And I listened very thoughtfully as they shared the issues that they intend to come forth with. And as I listened, I got excited. And I assured them, I'm going to be here. I was going to show up because I wanted to hear from their perspective. And then the traditional forums, conversation, conventions, you spend too much time reading the bio sketches, the resumes of the speakers. And I'm not going to do that. Let me assure you, we have the best of the best. We thought about the topics and how we could get a different framework, and we also agreed to give them the time so they want to rush through their comments. Dr. Flores, Glenn Flores, and hear me clearly, Distinguished Chair of Health Policy Research, Medical Research Institute, and Research Affiliate, the Department of Health Sciences Research, Mayo Clinic. When I think of Mayo Clinic, I think of the best place in the world to go and get fixed. Go to Mayo Clinic. But to have a colleague to talk about the policy which drives getting it fixed is exciting. Alfonso Rodriguez Lance. And I was particularly excited because I saw the degree PhD, and that's okay, but I saw DVM. I'm at Tuskegee, and we've got an outstanding School of Veterinary Medicine. So we've got a physician, we've got a veterinarian, and by the way, I'm a dentist. So we've got a real rich opportunity. So we'll have the speakers come forth as they're listed in the program, and we'll have this conversation because you have as much to give as we do. I look forward to the dialogue. Dr. Flores.
So thank you for that kind introduction. So this is the Getting the Data Right for Latino session. I'm going to talk about appropriate language and subgroup data are critical for public health and social justice. So the objectives of my talk will be to talk about the prevalence of limited English proficiency, which I'll refer to as LEP, among U.S. Latinos, how language barriers impact health and healthcare, why LEP is the best measure of assessing language barriers, the collection of language and LEP data in clinical settings, national surveys, and research, and finally, the importance of collecting data on Latino subgroups. So, just as a backdrop, the world's population of 7.3 billion people inhabits 191 countries and speaks over 6,000 languages. And between 1990 and 2014, the number of people in the U.S. speaking a language other than English at home rose from 31.8 million to 63.1 million. And the number of LEP Americans grew from 14 million to 25.6 million. And LEP, as has been mentioned before, is defined as the self-rated English speaking ability of less than very well. That's using the census questions, which we'll get to later. Being a pediatrician, I always like to take a look at what's going on with kids, and we know that almost 12 million school-age children, so that's 22%, speak a language other than English at home, and that's a number which has tripled since 1979. And we also know that Latinos absolutely dominate the speakers of non-English language at home and the LEP. So we just said 61.3 million Americans, so that's 21%, speak a language other than English at home. While Latinos who speak Spanish make up 39.3 million, so that's 62% of that group. And then 25.6 million Americans, or 9%, are LEP. Well, Latinos make up 16.4 million, and that's also about 2/3 of everybody in that group. By comparison, when you look at Asian Pacific Island languages, it's about 4.5 million, or 19%. Other Indo-European languages, it's 3.4 million, or 13%. And then all the other languages are a little under 1 million, it's about 4%. So, a lot of you know there is a federal mandate for providing language services for LEP Americans. So Title VI of the Civil Rights Act of 1964 clearly states that denial or delay of medical care for LEP patients due to language barriers constitutes a form of discrimination. And this actually requires that all Medicaid and Medicare recipients, which is almost all providers of clinical care, have to provide adequate language assistance to LEP patients. But in spite of that, we know that language problems impact multiple aspects of healthcare. We know that they impact access to care. We know that they impact health status. We know that they impact the use of health services, patient and physician communication, satisfaction with care, and quality and patient safety. Unfortunately, I only have 20 minutes because I could spend a few hours about this, and I encourage you to take a look at, for example, the review that we did a few years ago that's cited there. So just a few of the key issues for LEP patients. When you look in psychiatric settings, we know that LEP patients have a greater likelihood of a diagnosis of more severe psychopathology. They're more likely to leave the hospital against medical advice. They're less likely to establish a good rapport with their physician. They're less likely to receive an adequate explanation of their therapeutic regimen, and they're less likely to give feedback to their physician. And then there are some recent studies that document especially egregious hazards of using ad hoc interpreters for LEP cancer patients. So an ad hoc interpreter is an untrained person. They can be untrained staff, like a medical assistant. They can be the custodian, Jose, who's cleaning the floor, and somebody grabs and said, come interpret. They can be somebody pulled from the waiting room, and even people pulled from the streets. So, and we've done a lot of work on this. I'll just very briefly touch upon it a little bit later, but I want to show you some examples from the literature specifically for LEP cancer patients, and these are some examples. So in one case, the physician said, we think there is a 40% chance that the treatment will prolong your life. And the interpreter said, the treatment will prolong your life. In another case, the physician said, the doxy, referring to a chemotherapeutic agent, doxorubicin, could hurt your heart. And the interpreter said, the doxy can give you pain. The physician in the next case says, the results of these tests lead me to conclude that you do have breast cancer. And the interpreter says, this test will tell me if you have cancer. And then finally, one important thing that you have going for you is the fact that the cancer has probably been caught early, which the interpreter interpreted as, one important thing is the fact that the cancer is working quickly in your body. We also have found a few studies that are, I think, equally striking. There's one study of a major pediatric residency program. By the way, for you trainees, I'd encourage you to do these sorts of studies because there's not enough. And this study found that 68% of pediatric residents spoke little or no Spanish. 53% of the non-Spanish proficient residents, however, used their inadequate language skills in patient care often or even daily. And many residents reported that LEP families under their care never, only sometimes understood their child's diagnosis over half the time, medications over a quarter of the time, discharge instructions 43%, and the follow-up plan 40%. And 80% of these residents reported they avoided all communication with LEP families. You can think about how good the care was then. And then although all of these residents agreed that hospital interpreters are effective, 75% reported never or only sometimes using hospital interpreters. And then I had a medical student who was very ambitious, and so we did a study together, looked at 128 pharmacies in a major U.S. city. Any pharmacists here? Well, what we found was that about half of the pharmacies can never or only sometimes actually prepare non-English language prescription labels. Over half of the pharmacies never or only sometimes can provide these non-English language information packets, including 15% who can never do it. And about 2/3 of the pharmacies never or only sometimes can orally communicate in non-English languages, including 1 in 6 who never can do so. We know that health processes, outcomes, and use of services will end up being better when you have interpreter services. We know that they positively impact these outcomes. So one study a few years back of children presenting to the emergency department found that LEP patients with professional interpreters did not differ from the English proficient patients in test costs, use of IV hydration, and then also had a lower likelihood of testing. We know that LEP patients with type 2 diabetes who have trained professional interpreters are actually 2 times more likely than people who speak English to receive care meeting American Diabetes Association guidelines. They're 3 times more likely than English proficient patients to have dietary consults, and they don't differ from these English-speaking patients in 18 other processes and outcomes. I wish my friend Eliseo was still here because I'm going to quote one of his great studies. He looked at patients with hypertension and diabetes and found that health status, physical functioning, psychological well-being, health perceptions, and even pain scores were higher, meaning better, in those who had language concordant versus discordant physicians, so a physician who spoke their language. There are also a number of studies on quality and patient safety. So in one study of a large children's hospital in the Pacific Northwest, they found that there was a 2-fold increased risk of serious medical events in Spanish-speaking patients requesting interpreters versus those who did not. And these serious medical events include 10-fold medication errors, missed or delayed diagnoses, failure to monitor patients, diagnostic procedures performed on the wrong patient, the wrong diagnostic procedure performed, and administration of breast milk to the wrong patient. And here's some of the cases that we've reported on. So a 2-year-old fractured her clavicle after falling off her tricycle. A resident physician misinterpreted 2 Spanish words, se pegó, diagnosed the child with child abuse, and contacted the Department of Social Services, who, without an interpreter, actually had the mother sign over custody of her 2 children. In another case, a 10-month-old girl with iron deficiency anemia was given a 13-fold overdose of iron and hospitalized for iron intoxication after her LEP parents were given medication instructions and a prescription only in English. So the parents gave 15 milliliters, so that's 1 tablespoon, of iron elixir based on the prescription label that read 15 milligrams per 0.6 milliliters, 1.2 milliliters daily, so that's like a dropper. And then there's a famous case where there was misinterpretation of a single Spanish word. It was intoxicado in Florida, which resulted in an 18-year-old's quadriplegia after being misdiagnosed with a drug overdose. The patient's hematomas, brainstem compression, and paralysis were due actually to a ruptured aneurysm, and the hospital paid a $71 million malpractice settlement. And I also want to share with you, this is an actual case that occurred. So Juan was a 6-month-old, previously healthy male who presented to a children's hospital ED with new onset vomiting and diarrhea. The triage history given by mom was interpreted by Juan's 12-year-old sister. Needless to say, she was not trained as an interpreter. And the sister stated that the patient had 4 dirty diapers and 3 episodes of vomiting that day. Juan was triaged to a non-urgent level of care in which documentation stated he had vomited 7 times that day with no diarrhea. He was discharged shortly thereafter with a diagnosis of vomiting and instructions in English only for Pedialyte PO ad lib, that means by mouth. 3 days later, Juan returned to the emergency department. He was in severe distress. He had new onset of bloody stools. They admitted him to the hospital, and he died 6 hours later of septic shock. So I want to talk very briefly about a study we conducted that was published in the Annals of Emergency Medicine. We looked at errors in medical interpretation and their potential clinical consequences. We looked at hospital interpreters versus ad hoc interpreters versus having no interpreter, and that's the case where, in many cases we saw this, where the adolescent had to interpret about himself for his mother and to the doctor. So we found that compared with ad hoc interpreters and having no interpreter, the professional hospital interpreters, as you might expect, result in significantly lower proportions of omissions during the encounter, false fluency errors, and errors of potential clinical consequence. And ad hoc interpreters and having no interpreter can cause miscommunication, a lower quality of care, and interpreter errors that have the potential to cause medical errors. And I want to share with you one of these interactions. This was published in the New England Journal of Medicine. So this is multiple admissions and false fluency errors. This is a 12-year-old who came into the emergency department with dizziness and no interpreter. So the mother says, la semana pasada él le dio mucho mareo y no tenía fiebre ni nada, y la familia por parte de papá todos padecen de diabetes, which means last week he had a lot of dizziness and he did not have fever or anything. His dad's family all suffer from diabetes. So, of course, the adolescent, not being a trained interpreter, says nothing, and the doctor, not knowing Spanish, says, uh-huh. And the mother says, a mí me da miedo porque él lo que estaba mareado, y no tenía fiebre ni nada, which means I'm scared because he's dizzy, and he didn't have fever or anything. So the doctor says, okay, so she's saying you look kind of yellow. Is that what she's saying? And the patient finally says, and as he's asking his mother, es que si me vi amarillo, which means, is it that I looked yellow? And the mother says, estaba como mareado, como pálido, which is, you were like dizzy, like pale. So the patient finally turns to the doctor and says, like I was like paralyzed, something like that. So why am I bringing up all these cases and telling you about stuff that doesn't necessarily have to do with data? Well, I want to now move on to something, which is there is a bewildering array of methods for collecting language data. So, of course, unfortunately, what we see all too often is a positive response or nod of the head to the question, do you speak English, when someone's coming to the hospital or clinic. Sometimes it's just a quick take by the registration clerk or a researcher. Some people classify the language of interview. Some people say, what's your preferred language? Some people base it on, did you request an interpreter? More and more, we're seeing primary language spoken at home, and then also the U.S. Census questions on language spoken at home and LEP. So what the heck works best? So evidence actually documents that LEP is the best measure of language barriers. And we conducted a study of 1,100 children and caregivers, it was published in the Public Health Reports, to compare primary language spoken at home versus parental LEP and their associations with health status, access to care, and use of health services in children. And the key study findings were, after we did multivariable analyses and we adjusted for all kinds of covariates, we found that parental LEP was associated with triple of the odds of a child having fair or poor health, double the odds of a child spending at least a day in bed for illness in the past year, and significantly greater odds of children not being brought in for needed medical care for 6 of the 9 access barriers to care that we looked at. So couldn't afford medical care, uninsured, staff doesn't understand culture, transportation difficulties, appointment difficulties, and the clinic is too far away. On the other hand, primary language spoken at home was not associated with any of these health status or access outcomes, which to us was pretty conclusive evidence that this is what we need to be doing. But collection of language data is unacceptably low in clinical settings. So a national survey of 272 hospitals revealed that only 39% collect any data on the patient's primary language, and no statistics were available or presented on what proportions of hospitals or health plans collect LEP data, if any, and I emphasize if any because I suspect it's close to zero. In another study, a national survey of internists documented that 65% have active LEP patients. This is nationwide. But few practices have a formal mechanism for obtaining data on the patient's primary language, and only 28% record the patient's primary language in the medical record, and again, there was no mention of whether any LEP data were collected. Another issue that I think is really important right now is no national surveys currently collect LEP data. And here's some examples, and I apologize because I know I might be not being a politic guest because some of these are from the National Center for Health Statistics, but it's something that's troubled me as a researcher for decades, and I've been trying to have people think about having LEP in the question. So in this slide, in the first column, you see the survey. Is that showing up? Here we go. And the second column is the language measure, and the third column is was LEP assessed. So NHIS, for example, the National Health Interview Survey, looks at the interview language, and there's no LEP assessment. And NHANES looks at the language usually spoken at home, no LEP assessment. NSFG, that's the National Survey of Family Growth, primary language, but no LEP. SLATES is also primary language, but no LEP. And then the National Vital Statistics System, National Death Index, and NAMCS is the ambulatory survey. They don't, as far as I know, they don't look at a language measure, and they definitely don't look at LEP, and this was taken actually from a site that showed these. Now, another thing that really is troublesome, and I think really speaks to ethical issues, is the exclusion of LEP subjects from clinical research is actually rampant. So a really, I think, probably the most excellent article in the field. This is an analysis of 172 studies published in major medical journals, and it found that 74% absolutely excluded LEP subjects. And the most common reason for excluding LEP subjects was not having thought of the issue, 51%. Barriers to enrolling LEP subjects that were cited by the researchers included lack of pre-existing instruments in the target language by 58%, the need to translate responses into English, 55%, the expense of instrument translation, 45%, and recruitment of bilingual staff, 45%. And of those who actually included LEP subjects in their research, 95% reported that they spent less than 1/5 of the study budget to include LEP, and 36 actually needed no additional funds to include LEP subjects. So it really isn't expensive. And about 1/3 of the researchers believe that the study results would have been very different if the LEP subjects were excluded. And now another interesting study came up, and it showed that English fluency requirements have actually increased over time on clinicaltrials.gov. So clinicaltrials.gov is the federal registry where you go if you're doing a randomized controlled trial. And this is a recent study. It looked at over 10,000 clinicaltrials.gov's protocols from before 1995 all the way through 2013. And it showed that 7% of these clinical trials overall required English proficiency of their subjects. The EP requirements, English proficiency, in the trials has actually increased steadily from a low of about 1.5% of the studies in 1995 to 1999 to now 9% in 2010 or later. The U.S. federal government at about 13% and NIH at 6% actually have significantly higher English proficiency requirement rates versus the industry, which is interesting at 2%, excuse me. And the English proficiency requirements vary by intervention category. So interestingly, the highest barrier was 28% for behavioral intervention. So they had the highest requirement of English proficiency. That was followed by procedure studies at 8%, devices by 5%, and a low of 0.4% for biologics. And another study that looked at IRBs came to the conclusion that we have insufficient federal and actually international guidance on LEP research subjects. So this was a review of policies and procedures on 30 U.S. IRB websites, including 23 of the top-ranked medical schools in research. And in this slide, what you see is the first column is the IRB policy, whether it was addressed or not, and the second column is the proportion that actually did so. So the highest was translating the completed consent document. That was 97% surveyed. Discussed language barriers in research, that drops to 53%. Guidance on using interpreters, 40%. Ethical or legal problems enrolling subjects when there are language barriers, that's only 20%. Problems with excluding LEP subjects from research, 17%. And then guidance for translating other research materials, those are things like questionnaires or surveys or brochures, 7%. So here are the key conclusions that the author reached on this IRB study. So intentionally excluding LEP people would be unfair to potential LEP subjects. The principle of justice discussed in the Belmont report requires fair procedures and outcomes in subject selection. It is unfair to exclude research subjects from a study without a valid scientific or ethical reason. They also concluded that intentionally excluding LEP persons may violate federal research regulations, which state selection of subjects should be equitable. In making this assessment, the IRB should take into account the purposes of the research and the setting in which the research will be conducted, and should be particularly cognizant of the special problems of research involving vulnerable populations. So, despite all this, assessing LEP really actually is easy in clinical practice and in research. And it's just a two-part U.S. Census question. So does this person speak a language other than English at home? If they say yes, then you go to the next question. If no, you skip it. And then you want to ask, of course, what this language is. And then all you ask is, how well does this person speak English? Very well, not at all. And any response to this question that's not very well should be classified as LEP and actually means that this person needs an interpreter. So now I want to shift gears and talk about the importance of Latino subgroup data. And my predecessors today, Dr. Perez-Table and Dr. Dominguez, did a nice job of talking about some of these issues, but I want to focus on one aspect, which is that substantial health and healthcare disparities exist by Latino subgroup. These subgroup disparities may actually equal or even exceed those among the big racial and ethnic groups, but Latino subgroup data are not consistently collected in clinical practice, in national surveys, or health and healthcare. So my first paper as a faculty member, one of the first, was American Journal of Public Health many years ago, and I actually looked at childhood disparities in social health and healthcare measures. And I know this looks a little complicated, but hopefully by walking you through it, it'll make sense. So your y-axis is percent, the x-axis, the different measures. And what I've done is I've lined up the 5 major racial and ethnic groups: white, African American, American Indian, Alaska Native, Asian Pacific Islander, and then Latino as a whole. And then at that time, I was able to look at Cuban, Mexican, and Puerto Rican. And what you're going to see consistently is that the subgroups equal or exceed the magnitude differences of the major racial and ethnic groups. So if you look at family poverty, as many of you know, very high rates in African American and American Indian populations. If you look at Latinos, so they're sort of short of that high, but definitely higher than whites. Break it down by subgroup, and you can see Cubans are almost like whites. Then you have Mexican Americans who are about equal to the poverty rates in African American and American Indian, and then Puerto Ricans are actually off the charts there. When you look at the educational attainment, which was alluded to earlier, you see the same sort of patterns where you look at the first 5 groups here, racial and ethnic groups, and you see major differences, and not surprisingly, Latinos are high. But within that Latino subgroup, you obscure those differences because you look at Cubans, and they have actually pretty good rates that are not that far away from whites, but off the charts are Mexican Americans. Then we move on to health and healthcare. Look at health status not being excellent or very good. You see, again, the 2 major ethnic groups, racial and ethnic groups, are high, that are higher: African American, American Indian, and Alaska Native. White are low, and Latinos, again, are sort of in the middle. But you look at Cubans, they're actually doing well, and then Mexican Americans and Puerto Ricans are about at the same level as the worst racial and ethnic groups. Bed days for illness in the past year, more or less the same pattern, and then going a year since the last physician visit, same sorts of things where you see these subgroups either meet or, in this case, Mexican Americans exceed the differences in the major racial and ethnic groups. And you see this in study one after the other, and I'm only going to touch upon a few. Dr. Peristabile mentioned the SOUL study, and this is a slide. It actually looks very complicated, but I'm going to draw your attention to a couple of key findings. So when you look at hypertension, for example, you see a low in South Americans of about 20%, and this is in males. And then the high over here, it's actually in Dominicans, of 33%. Same thing with females. You see lows of 16% among South Americans, and then a high among Puerto Rican women of 29%. When you go to smoking in males, you see similar disparities within Latinos. So Dominicans have the lowest rate of smoking at about 11%, and then 3 times that rate in males who are Puerto Rican at about 35%. When you look at females, you can see really big differences in obesity rates, so about 31% for South Americans, and Puerto Rican women are 51%. And then take a look at diabetes, and you see a low of 9.8% among South Americans, and Puerto Ricans are 19.4%. And then this is another study where I've broken out the diabetes subgroup disparities in the U.S. So if you just look at white, African-American, Latino differences, you see whites are about 7%, African-Americans very high at 10%, Latinos are 7%, so they seem like, it's not so bad, right? But then you break it down by group, and in this case they had a number of groups. You see South and Central Americans actually have a very low rate at 4%. Dominicans are also fairly low, 5%. Cubans, then you jump up to 8.8%. Mexicans are equal to African-Americans, 10.2%, and Puerto Ricans are actually the highest. So if you did not look at these subgroups, you would think, Latinos are doing pretty well. Here is a study on cancer mortality disparities in Florida. So you're looking at the rates per 100,000 population. And in this case, as has been alluded to earlier, you see whites, of course, have a very high rate, whether you look at women in pink, women in orange or men in pink, and it's 253 versus 376. Latinos, they look like they're doing well, 170 and 290. But again, you start with the Mexicans, and they're actually doing fantastic in comparison. But then as you go to other Latino, unfortunately, they clumped a lot of the groups, and then Puerto Rican, you get higher, and then by the time you're at Cuban, you're actually getting pretty close to the white rate. So again, if you just looked at Latino, you would think they're doing all right, but you can see the subgroups have some fairly dramatic differences. And then I believe this is actually a CDC study. This is on HIV mortality disparities. This is the age-adjusted HIV death rate per 100,000. And you look and you see that whites, of course, have the lowest rate, about 11. African Americans have the highest at 122. And Latinos, again, they look like they're doing all right, about 28. Break it down by the groups, and you see that Mexicans are low, as well as South and Central Americans, about 17 or 18. Dominicans are also fairly low, 19. Then you get the Cubans, you're up to 36. And Puerto Ricans, you're almost to the African-American rate. You're at 101. So again, by just looking at this, you would miss all this richness. So in conclusion, 16.4 million Americans, so that's 1 in 18, are LEP and speak Spanish. Language problems impact multiple aspects of healthcare: access to healthcare, health status, use of health services, patient and clinician communication, satisfaction with care, and quality and patient safety. LEP is the most helpful data source in assessing impact of language on health and healthcare, but most hospitals and medical practices do not collect any kind of language data, and LEP data rarely are collected. No national surveys in the U.S. collect LEP data. And a review of major medical journals documents that 74% of studies exclude LEP subjects, and the most common reason being not having thought of the issue. Substantial health and healthcare disparities exist by Latino subgroups, so these subgroup disparities may equal or even exceed those among the major and racial ethnic groups. And failure to collect Latino subgroup data can result in adverse consequences, which include over-testing of low-risk subgroups and underdiagnosis and inadequate treatment of high-risk subgroups. And finally, implications include to ensure optimal healthcare quality and outcomes, ethical care, and equity, data on languages spoken at home, LEP, and Latino subgroup should always be collected for all patients and primary caregivers of children on national surveys of health and healthcare and in health and healthcare studies. Thank you.
Well, thank you, and thank you for sticking around after lunch. It's been a long day, so it's great to see a lot of very motivated participants. And I want to say that what awareness has been very nice, calling us, great experts. I don't consider myself one of the best experts. I consider to be a very, very persistent person in terms of looking at this issue. So I think that the presentation by Dr. Flori has been excellent in terms of he's done a great job in presenting some of the issues related to research and clinical care and data collection and language access issues related to those areas. So now I want to just start thinking a little more in terms of what does it mean for public health, and particularly for public health surveillance. Since in the CDC, public health surveillance is one of the main activities or the base for many of the public health action that we do. So we're going to be talking about the issue of the importance of migration when you're thinking about Hispanic health, and actually about health of the US population in general, the importance of including Latinos in national data systems, and particularly surveillance data systems. What are some of the ethical considerations, and finally some recommendations. So we've been hearing a lot today about the tremendous diversity of the Hispanic population by national origin, culture, language, place of birth. But what I think is one of the areas that is frequently forgotten, even though sometimes it's mentioned, is the importance of immigration in Latino health. Immigration is one of the main driving forces for the increased race ethnic diversity in the US, and particularly for the increased diversity in the Latino population in the US. Not only the immigrants, but also the children of immigrants born in the US. And even though migration is considered to be one of the main demographic factors affecting health, including fertility, mortality, I believe it's frequently forgotten when we think about public health, and particularly in data collection in public health. Here, I want to highlight, besides this diversity of Latinos include indigenous populations that may not speak Spanish, have been mentioned in the past, and also Afro-Latino populations. So when I'm talking about migration and migration-related factors or variables, I'm specifically talking about place of birth. And that usually means the country where you have been born. For Puerto Ricans would be if you'll be born in the island of Puerto Rico or born in the continental US. Very different health issues and very different populations. Also includes how many years have you been living in the US, specifically for the foreign-born. Immigration status is a very important immigration-related issue. Are you a citizen of the US? Are you non-citizen? Are you an asylum seeker, refugee? Undocumented, very, very important, significant impact in health of populations. And finally, language. We hear a lot about language. I don't mean talking as much about language data collection, but focusing also or adding a discussion about the importance of providing language access to people who don't speak English from a public health surveillance point of view. So just to illustrate one more time, we can show tons of numbers and graphs and tables, but I think this kind of slide tries to illustrate some of this diversity within the Hispanic population. Here I just use an example of Mexican American. These three individuals may consider themselves very likely Mexican Americans. One of them is born in the US, is a US citizen by birth. He speaks English and speaks very basic Spanish. The one in the middle, she's born in Mexico. She has a green card, she's a legal permanent resident, has been living in the US for 10 years, she's a long-term resident, and speaks Spanish in very, very basic English. The third one is a woman also born in Mexico. She came as a child, as an unaccompanied minor, looking for asylum, and she's been only 2 years in the US. She speaks Mixteco, it's an indigenous language from Mexico, doesn't speak Spanish, doesn't speak English. So tremendous diversity within this, in this example, in terms of life experiences, exposure to different cultures, health, issues in their countries of birth and also in the US, and also in terms of communication needs, even just the language that you will communicate with those individuals. So with the 54 million Hispanics, a few points I want to add, because there is a loud misperception that all Hispanics are Mexicans, all Hispanics are foreign-born or undocumented. In fact, 65% of Hispanics are born in the US, 35% are foreign-born. Those born in the US include about 8.5 million Puerto Ricans from the island born in the continent. Also, 76% of all Latinos or Hispanics in the US are US citizens. The rest are many other types of different immigration status. And we hear about a very high proportion, 3/4 of Hispanics speak Spanish at home, and 1/3 of Hispanics are LEP populations. Now, why migration? I will try to make the case that why migration is an important factor to consider in terms of data collection, particularly. More and more, migration is identified as a specific and individual social determinant of health. It's a marker of social vulnerability. There are many issues that affect a migrant that interact with race, ethnicity, poverty, and other indicators of vulnerability. And I believe that they have to be considered together with these other more traditional indicators of social determinants of health to really get a good picture of what are the determinants of health in populations. Immigration also tremendously affects access to care. Just by migrating, frequently there is a breakage in the continuity of care for a number of conditions. Your practices, attitudes about access to care might be very different depending on where you have been born. So it's a very important factor in access to care and quality of care. And also, it's a very important factor in disease risk. If you're born in Mexico and Brazil, the environmental, infectious diseases, and others, occupational, et cetera, that you might be exposed in other countries might be very different than those you might be exposed here. And by migrating, then you might have a combination of both type of exposures. It's very, very important to take to account in terms of disease risks. Neglected diseases like Chagas disease, cysticercosis, they have a higher burden for foreign-born populations. And by the way, they are not routinely monitored in our national surveillance systems. Other diseases like hepatitis B or hepatitis C, are more frequent in the US-born Latinos. Migration data is also very important to identify health disparities. I will show you in a moment. Not only analyzing the data by Hispanic origin, but you add the information about country of birth or being foreign-born or US-born, that really helps you to identify some additional disparities that you might not see otherwise. And finally, this is not just an exercise of making more and more complex maps and talking about all these different populations. Really, I think that the objective of collecting this data is because it really allows you to identify those disparities for specific populations, and then you can target the limited resources that we all have to the specific population that have the highest burden for those conditions. So it's collecting the data is a way to have more cost-effective targeted programs to go where the problems are and where the most underserved populations are. And this is just an example. Dr. Flores mentioned before the differences between Hispanic origin groups and health insurance. So this one is going to one step, additional step that I think we need to take. If now we break this data by US-born versus foreign-born, we still see the Latinos have lower health insurance level compared to the whites. But then also we see that the Mexicans among the Latinos have the worst access to health insurance in terms of the percentage that don't have health insurance. But I think it's also very, very obvious from this data that for every single race ethnic group, the foreign-born has lower health insurance than the US-born population, including the whites. But also that we see that the foreign-born Mexicans have almost 5 times, or in this case, almost double the disparity in access in health insurance than the Mexican-born population. So by adding this additional piece of data about the place of birth, you're able to further identify populations that have even greater disparities that you can identify just by looking at race, ethnicity, or race, ethnicity, and origin information. When I talk about the need to provide language access, what do we mean by that? And first, I think we're talking about the need to provide data collection instruments in Spanish, at least. Now we're talking about Hispanic populations, but we should consider obviously other languages too. Just by translating the instrument frequently is not enough. There is a lot of different cultural meanings of words. Many societies don't have certain words that we use in English, and there is no direct translation, or there is no specific word to translate that. So beyond the translation is really ensuring the equivalence, that the questioners have the same, or the questions have the same meaning for different cultures. It's very, very important to read to get really quality data that you need. This is particularly important, again, for Latinos, because we hear there is a lot of high proportion of the Latinos are low literacy, low education, so it's even more important for those populations. Having the document or the Spanish translated document may not be enough. It's very important also if you have the possibility of you can do it, to have an interviewer to actually ask the questions in that language, a bilingual interviewer. And again, that has to do with low literacy of the populations, and it's a way to really for the interviewer to ask the questions properly and to consider other indigenous languages. Proper culturally appropriate outreach is very important too. That means something that we know that we need to do, working with the communities, engaging the communities, working with the community-based organizations and the leaders to really gain their trust, so they're more likely to participate in our data collection systems and to provide honest information. Now, this is just a rough example, it's an illustration, because I want to show you how a person who is limited English proficient who is being interviewed in English by an English speaker using an English language questionnaire. This is not true, this is not how our questionnaires look, how that person might hear. He might hear question one, okay, he's going to ask me a question. Do you ever, blah, 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 blah. Yes, no, don't know. I understand the last part, okay? So what do you think are the options for that limited English proficient person? One, doesn't want to participate. Say, sorry, I can't. Second, even worse, the surveillance system or the national data source might say, sorry, we don't have a translator, I'm really sorry, good luck. Third, they may answer, but they don't understand the question correctly, and they might provide you the wrong answer. Actually, you have a 30% chance of getting the wrong answer. So this is just a way to illustrate. This is not something that we're talking, it's an abstract idea, or it's not something nice for us to do. I consider it to be a tremendous necessity, and also a very, very important ethical issue, as we were talking a moment. So by not providing language access to this large population, for Latinos it's about 30%, for other populations even higher, you're going to have a lower participation rate in your data collection, so people are going to participate less, particularly in areas like California, like Texas and others, where you have even higher proportion of LEP populations. Secondly, the population that participate in your data doesn't represent the actual population, because who are more likely to participate? US-born, English speakers, or foreign-born, highly acculturated, better educated, better access to care, and these are the people you're going to be learning about. So how are you going to identify the disparities of the most vulnerable if you're not even including those individuals in your data collection? You're really shooting yourself in the foot, or living in a kind of ideal, not ideal, unrealistic world. The data is going to have lower quality because the person is going to respond whatever if they don't understand your question well. They may refuse to answer certain questions, in order they will respond, so you have missing data more than you could, and your studies have been proven that are likely going to be biased. So effectively, by not providing language access, we are making large proportion of the US population invisible, and also the data that you're collecting, your evidence that you're going to be using for policy and for funding, are going to be likely to be biased. So I want us to think about that while we're thinking about the cost of doing something. The There have been a number of assessments done at a national level, and Dr. Flores mentioned some examples of the availability of data on race, ethnicity, language, and migration in general. They have been identified there are many gaps in the data and also gaps in the quality of the data collected. We also did an assessment that we are ready to publish. We look at 130 data systems used by the CDC to conduct public health surveillance, looking at do they collect any of these variables. We found that the majority collect at least the basic Hispanic, non-Hispanic information, 82%, but only 20% collected more detailed, granular Hispanic origin data. 11% collected any language question, any, language spoken or primary language or language interview, anything. Place of birth was collected by 30%. We were surprised positively. Years of residence 16, immigration status 11, and also the questionnaire in Spanish only available in 20% of the 130 data systems that are used in the CDC to monitor disparities and to assess the health of the U.S. population and to respond to outbreaks, emergencies, et cetera, et cetera. So major gaps. So what does it have to do with public health ethics? As we mentioned many times, this data is very important to identify and address all these different needs of these different populations and better use the resources. You also, by collecting the data, you can learn where are the language and cultural needs of your population, so you can better serve those individuals, and they're more likely to follow your recommendations in terms of taking specific public health actions. Also, it will be better to identify inequalities, meaning unjust health disparities based on lowest quality of care being provided by specific groups. Maybe the Latinos overall don't have an equality on certain specific access to care services, but maybe the Puerto Ricans are, or the Mexicans, or the Mexican immigrants are. So only by collecting this data, you can identify the specific subpopulations that might be suffering inequalities. And something I think we need to be thinking very seriously, if we have a pattern of systematic exclusion of certain populations based on language, based on national origin, or in other important social factors, does it go to the level of are we conducting discriminatory actions in terms of the way that we do public health? Okay, language access, again, this is an illustration. If we don't provide language access, basically of these three individuals represent all the Latinos in the US, you will be saying, this lady on the left, sorry, we cannot include you in our data collection system because we don't want to use the resources to translate our materials into Spanish. We heard that for Dominicans, it's about 40%. For Central Americans, that are the largest populations in the US, 50% of the population. For Asian, it's about 50 to 60% of the certain Asian groups, like Vietnamese and Chinese, are also LEP. So tremendous, big groups of our population. Again, if we're doing it in a systematic way, we are excluding these individuals. Does it amount to discrimination in the way that we are collecting data? I think this is a very, very important ethical issue to continue discussing. Some additional areas I want to mention, minimizing risks. Many of the population that we are talking about are highly vulnerable populations. Some of them are probably, I will make the case, are some of the most vulnerable population that we have in the US. There is a high proportion of individuals, particularly immigrants, Latinos and Asians, who are victims of human trafficking. The US is one of the main destinies for human trafficking. This is what is called the modern slavery. So these are people who are being enslaved for sexual work, and more and more we find evidence for forced labor in agriculture and other places. So very, very extremely vulnerable populations. Unauthorized immigrants, asylum seekers, indigenous, very, very vulnerable population that is even more important to try to minimize the risk, particularly the risk of disclosure of information about these individuals so they don't suffer social stigma, or they're not being identified by immigration, or they have any of those legal consequences for participating in our data collection systems. We have very, very strong confidentiality and privacy rules. I think, again, because we're talking about collecting what could be sensitive information right now, particularly in political environment where you have a very, very negative anti-immigrant environment, People willing to admit I'm Mexican, good luck. People admitting I am Arab, is not easy. It's a very, very sensitive information right now. So we have to be even more careful that we are in regular circumstances. But we have ways to do that in the way that we protect the data and to protect the information of the individuals. And also to provide the autonomy of the individual to participate in our data collection, given that these are vulnerable populations. I think ensuring that the community participates, and by the community, I'm talking about the general US community. If we're talking about minorities, minorities have to participate in the different aspects of data design, analysis, and reporting, and that the data benefits really the communities who really need it. I have experiences where data is collected from the poorest, and then the resources are going to where the people who are working or the resources actually are. So really the data we collect and has to benefit the population that more needed. Cost, we don't think is an excuse, it's an enough excuse not to do anything. We cannot do everything that we could or should do, but I think that definitely there are many good practices and feasible strategies that we can implement with a lot of additional resources. And again, at the end, I think it's going to benefit us. There are many experiences of distrust in minority communities, in African American, Latinos, of unethical research and unethical data collection and experiments. It's even more important that we regain and maintain the trust of the community to be able for them to participate in our data collection, and they benefit also from what we're trying to do for them. So what needs to be done, and this is an older, I don't think I have them done US. So, what we need to do is know, based on this, the presenter and the co-author, we have very, very strong, excellent guidelines in the US about what do we need to do. And actually those guidelines, some of them have been, recommendations have been in place for decades. There is a 2011 HHS data standards that actually said that we should be doing what we've been talking about today, granular data, language data. Yes? 1 minute. Unfortunately, that only applies to population health surveys. I think that they should apply to all data collection systems. The National Cultural and Linguistically Appropriate Services guidelines do not only apply to healthcare. They also apply to public health programs and apply to epidemiology. And for me, that means that it applies to surveillance. So the idea of promoting cultural and linguistically data collection, translation, and interpreters also apply to surveillance systems. Less recognized, even though there is a lot of recommendations that are collecting this data, migration-related variables that I've been referring to before. And to conclude, I think there is a very, very strong consensus of what we need to do. We need to collect the data that we have been talking about today. We also, it's very important to provide language access. These recommendations could apply or should apply to most data collection systems. They're feasible. We have very good examples that can be done. Recently, the National Notifiable Disease Surveillance at the country of birth, a number of surveys collect data in different languages, so we know how to do it, and we know that it can be done. And finally, we know that the consequences, our data is going to improve. It's going to improve the quality and the capacity to monitor and address health disparities. These recommendations are based on ethical and social justice principles. It's not something that we're going to do because we're nice or just because of research. And also these recommendations are also critical to implement and to eliminate health disparities in the US and to improve the health of the overall US population. So I'm going to stop here. Thank you very much.
I know we've run out of time, but can I have 2 questions, and we'll conclude.
First of all, both excellent, really great presentations. This question is for Dr. Flores and has to do with the role of LEP. And one of the findings that we had in vital signs was that Hispanics have a higher rate of death from chronic liver disease. And so the question is whether LAP can play or maybe playing a role in that this higher rate of liver disease from lack of understanding the instructions on a label. So for example, over-the-counter pain relief. People think, well, one pill works well, maybe I'll take 2 or 3, and not clearly reading the instructions or understanding the instructions that are in English. And I was wondering what your thoughts were about that.
Yeah, it's a great point, and I think LEP affects every aspect of that person's medical care. By that I mean, okay, I need to call for an appointment. I pick up the phone, I call a clinic or a hospital. Very few hospitals actually have a phone tree that allows you to go to any other language, even Spanish sometimes. Then you get to the clinic. Do they actually classify you as LAP and say, okay, you need an interpreter? A lot of times they don't, or the family may be embarrassed and say, I don't need an interpreter. And then can you get an accurate history on somebody if you don't speak their language and you're not using an interpreter? And again, unfortunately, it's really dramatically bad how infrequently people still will ask for an interpreter when there's a language barrier. And so can you get a good history? And then can you do the right procedures? Can you send them to radiology and have them do what they need to do? Will they follow up with you? Is a great question. Sometimes people will have the interpreter come, they'll have a great encounter, they'll give them a prescription, and then they won't have the interpreter accompany the parent or the family to the registration desk and get a follow-up appointment or that specialty referral. Public health, I don't need to tell you, how can you communicate to populations if you're not communicating to them in their language? How will they know that they need to get the hepatitis B vaccine? So I think there's so many levels, and we know that a lot of Latinos will present much later in their disease course, probably for all of those reasons, including language barriers. So they're going to have more advanced disease, which is harder to treat, and they'll have higher mortality rates. So you can really see how this is costing everybody, not just LAP and Latinos, but everybody, because it increased healthcare costs and increased mortality.
Last question.
I also have a question for Dr. Flores. In alignment with what Dr. Rodriguez Lainz said about benefit to the community as an ethical issue, you talked a lot about not excluding LEP. Would you want to say anything about inclusion so that the results would be meaningful for that subpopulation and of benefit to them?
So what the benefit is to the population of including them in the studies?
That having a large enough sample size in the study to actually draw some conclusions.
Yeah, so they're out there. It's just that researchers don't make the effort to sample them. And so I think part of the implication of your question is, are we getting representative biopsies, if you will, of populations when we don't integrate LEP patients into study protocols and into surveys? And can we really draw the kind of conclusions that we're drawing about the populations, because we're leaving out a huge component? I mean, we're talking about, it's about 10% of the US population. Yeah. Did that answer your question?
Yes.
Okay.
Let's thank this powerful panel, please. We're on to our next panel.
Well, good afternoon. I'm Maureen Lichtveld. On a day-to-day basis, I'm professor and chair of the Department of Global Environmental Health Sciences. at Tulane University School of Public Health and Tropical Medicine. I'm proud to be a former CDCer. But today I'm really here as the president of the Hispanic Serving Health Professions School. And with me are three distinguished speakers. The purpose of this panel truly is to bring it all together for you. This is the so what panel, if you want to translate that in a popular fashion. All through today, I've been identifying the priorities that our speakers have mentioned, and so we'll ask you after this session during the break to use your little colored dots, green for very important, yellow for important, but something else has to happen, and red for we have to hold on that. So work with us through that. The three distinguished speakers today in this panel are Mr. Gersnet Jose Perea. He is the communications coordinator of Afro-Latin Forum. We had an excellent conference call, our speakers together, and Mr. Perea is also the co-founder of Columbia, New York, where he is promoting the Latinos of African descent. He has been praised for doing so much of this, so much so that he's been quoted as by the newspaper in New York as one of the Colombians making a mark in New York City. And it's not easy to make a mark in New York City. So. He holds degrees in Latin American history and in theology. Our second speaker is Dr. Norma Perez. Dr. Perez holds a medical degree from the Universidad de Monterrey in Monterrey, Mexico. She holds a doctorate in public health degree in international health and family health from the University of Texas, Houston Health Sciences branch. She's the executive director of the Hispanic Center of Excellence at the University of Texas Medical Branch in Galveston. She holds faculty positions in internal medicine, geriatrics, and preventive medicine. She is the executive director of Frontera de Salud, a student organization that provides free care for residents in the lower Rio Grande Valley. But most closest to my heart is she's my partner, tied to my hips as the vice president of HSHPS. Our third speaker is equally phenomenal. Dr. Rafael Sanchez Cardenas earned his medical degree from the Universidad Autónoma de Santo Domingo. He has a professorship in social and preventive medicine. He's been a professor in high schools, but he's also been a physician in hospitals. But we welcome him here, very distinguished as His Excellency, the Vice Minister of International Relations of the Ministry of Higher Education, Science and Technology in the Dominican Republic. I think he's closest to the Tuskegee because globally, Dr. Cardenas promotes the learning outside, learning globally for his students, and has 2-degree programs at Tuskegee. And so I will, at the end of the three speakers, bring the whole forum together for you. But before that, I will turn over the podium to Gersnet.
Good afternoon, everyone. My name is Gersnet Jose Perea. I'm as Dr. Litchfield mentioned, the Director of Communications and Programs for the Afro-Latina Forum. The Afro-Latina Forum is a nonprofit that focuses on emphasizing the importance of race when discussing Latinos, specifically to discuss that about U.S. Latino populations and to make sure that we're highlighting the race question and race issues for Latinos here in the U.S. And I want to just quickly give a shout out and thanks to Dr. LeBird and Julio, who have been a great contact, and Dr. Warren, who we've made connections, and that's why we're here. Also glad to see Dr. Lopez, with whom we're working with on a few questions. So what I'm going to talk about is, so let me disclaimer, I am not a health expert, so just know that, right? So for us in the Afro-Latino Forum, and I think one of the concerns that we have is that race and ethnicity for us are two separate issues that count very importantly and very independently. So that's what I'm going to talk about first. The designation, one of the issues that we have within the Latino population is that the designation Latino, and we use the arroba, if you see the @ sign, you're like, why is he using the @ sign? We use it to delineate gender equality. In Latin America, many groups do that, so it's not like we're the only ones. We're probably the only ones here, but the Latino population is, the designation Latino or Hispanic does not fully capture the social and economic inequalities that contribute to the high incidence of certain health concerns, especially amongst what we call subgroups, among Latino, Latina subgroups. So we can look at, say, okay, well, Latinos, and I think everyone here agreed because everyone has said that, right? We need to further look at the population. We can't just overgeneralize the Latino population. That's important. But there's a need to improve statistical reporting to properly identify particular health situations amongst, and for our focus, Afro-Latinos, but individual Latino subgroups. So one of the main points that we've been talking about today is about the importance of subgrouping in a national level, and I think that that's good, right? We talk about subgroups and we talk about nationality, but I think another very important point is to look at the racial diversity within those subgroups, right? Within those what we're calling subgroups, right? Data points are needed to track how Latinos are being identified and for better understanding the conditions within the Afro-Latino community, and in particular in other communities within the Latino pan-ethnicities, right? So Latino, Latinidad, Hispanic are pan-ethnic terms. Pan-ethnic meaning they're already grabbing a broad of ethnicities and lumping them into one. So our emphasis and our focus and our challenge, not only as panel, as people who are attending this forum, but as people who work in the public health field or in the education sector or in the social justice sector, is to look at those distinctions within the groups and to further parse out this pan-ethnic term to look at certain situations more holistically. The experience of those subcommunities or subgroups, as we're calling them, especially when considering Afro-Latinos in particular and other Latino groups, affects access to health education and also affects the outcome. And I think that that's an important point, that we have to count the experience of the communities. Not only are we looking at certain generalizing factors, where we have to look at access, socioeconomic factors, locality, education. All of these contribute to health education, and also outcome. I'm quoting a paper here by Dr. Borrell. Dr. Borrell, she's based out of Lehman College with some other colleagues, and she says that she did a study on hypertension, and her study on hypertension said that this finding shows that Puerto Ricans and Dominicans have a greater probability of reporting hypertension than whites, are more significant, and are more similar to reporting from blacks. Why would that be? It is worth noting that Puerto Ricans and Dominicans have stronger African ancestry, exposing them to racial discrimination. So when we're talking specifically about hypertension in her paper, when she talks specifically about hypertension, she's trying to emphasize that racial discrimination by phenotype, right, by race, is what contributes to a higher self-recognition of hypertension, which we would not be able to look at if we just say, well, let's just look at how Puerto Ricans identify. Well, Puerto Ricans identify in X number, Dominicans identify in X number. Sure, but let's look at that population in more accurately. Also, Black Puerto Ricans identify as 66% suffering from hypertension due to racial discrimination versus 20% or 10% from white Puerto Ricans or white Dominicans looking at that situation. And she concludes in this, and this is a very important point. In fact, several studies have underscored the importance of race or skin color among Puerto Ricans and Hispanics as a whole when it comes to health outcomes. So I think those are the current problems, and that's why I label this part current problems. The current problem is that we either have, and I'm going to come to some solutions later, but I think we have a lack of understanding or a difficulty in understanding the diversity within the Latino population. I was really glad to hear Dr. Rodriguez-Lainez use the term Afro-Latino. As the first speaker today, I use the term Afro-Latino, even though we've all spoken about Black Latinos in different ways. Using the terminology also matters in how we're looking at groups, using different terminology and using language that can be, that communities can understand is a very important part of the situation. So some of the problem is that we don't fully understand the Latino population. I think everyone here understands that the Latino population, Hispanic population, is a broad population. I think everyone understands that it has multiple ethnic groups, but I think it's insufficient to only look at nationality. I think that we need to look within nationality at race problems, and I think that although we can, I know that in biology we go, oh, well, it's about genes. I think that's a part of it, but I think racial experience has is a big determinant to health access and health factors. So what are some of the implications? And she wrote some implications here that I really like and I wanted to highlight. The findings for Puerto Ricans and Dominicans of a higher probability when reporting hypertension underscore the need for data collection of health information beyond the traditional racial ethnic categories. And I want to highlight that point. I think that it's very important when we say racial ethnicity, race ethnicity, and we use the slash, but they are very different. There are two different constructs. Race is a completely different idea, and yes, we can say race is a social construct. Technically, so can ethnicity be labeled a social construct that's not really that doesn't accurately depict the population. So in order for us to get a more accurate result or get a more accurate understanding, we need to improve the data collection, so that we're able to understand these different categories, and we need to expand that. So it's not sufficient. So I like what Dr. Flores said. It's not only sufficient to ask certain questions in another language, which are important. That's very important. But it's also sufficient to ask race questions in those languages as well. And why does that come? In all of Latin American nations where we come from, there's a census, and a race question is in every one of the country's census. We were just talking about that over lunch with a few colleagues, that the race question is already part of the mindset of people who are Hispanic. It's the way that we're asking the question that becomes the problem. Just saying, oh, we just need to simplify the question and ask one doesn't really remedy the situation. She says the other point, moreover, the findings associated with nativity status for Puerto Ricans and Dominicans contradict the overall Hispanic paradox, underscoring the diversity of the Hispanic population and the danger of ignoring this diversity when presenting aggregate data for the population. And I want to say that that's important when we're looking at specific nationalities or subgroups, right? So if we look at Colombians, we say, oh, Colombians suffer whatever on whatever, insert your health problem here. That situation is going to look differently once you look at the racial categories within Colombian populations. And the risk of using the aggregate data on Hispanics is exacerbated when these data are used to extrapolate the geographic areas in which the highest proportion of Hispanics are not represented by the subgroups with the lowest or highest prevalence of, and I wanted to put like blank, insert your element here. In this case, it's hypertension. I think when we look at the subgroups and we look at the Hispanic population, we have to be able to look at the data specifically. And I think that helps us get to more accurate health situations and health solutions. So some of the solutions that like Dr. Litchfield said, that we're going to talk about at the end of this capstone session, we need to improve the infrastructure for measuring diversity within Latino groups. And then a further quote that I got from a research, I forgot the name of the doctor in Harvard, the U.S. infrastructure for measuring disparities remains inadequate at both the federal and the state levels. And that's going to tie to the next point. We need to attract more multilingual, multicultural people in the health sector in order to do these surveys, and that these two issues tie together. So the reason why we don't have good ways to measure diversity within Latino groups is because we don't have many diverse people conducting or in the rooms conducting questions to measure Latino groups, right? So Dr. Perez-Stable mentioned that at the beginning of he said, well, it's only 3%, 2% of the people in the science research sector were African American, 3% were Latino. If we don't have a diverse a body that's constructing these questions and that's asking these questions and that's forming the research studies, we're not going to have an understanding of why a diversity is needed and why asking for diversity is needed for the populations, because we just don't have that perspective. For me, I'm Colombiano, and I'm black, and so I consider myself Afro-Colombiano. And so for me, I already understand that it's already part of my makeup to understand that I can't just generalize and say we're all Colombians are like this. For me, it's already part of my psyche to look further and to segment the population. That's not the case if the people who are forming questions or the people who are conducting research are not diverse. So I think that those two issues go together, right? The infrastructure is wrong. Why? Because we don't have a lot of people in those sectors. And then it ties to this one too: accurate reports of race and ethnicity across all sectors of society and policy, not accurate, but also standardized. And I think that was an important comment that Dr. Perez-Stable made in the keynote, and that everyone else kind of has touched upon. If the Census Bureau is what delineates what we all use, then shouldn't we fight against the Census Bureau measure that's looking to erase racial categories in the census? If we have to norm ourselves because the Census Bureau says, you know what, let's just count all Hispanics as one race. But we say that's not a good thing. So shouldn't we then fight? We can't just say, well, the census said it, so we have to do it. Then we have to be the ones to look at that. And the so what, as Dr. Litchfield mentioned, the so what. Number one, I think that it further unravels socioeconomic factors and their connections to health disparities. I think that we have to look at that, and I think looking at race helps us look at socioeconomic factors. Every Latin American nation does racial counting in health sectors. It's not like we're asking, or it's not like I'm mentioning some novel idea. Latin American countries do this all over the world. As Julio could probably tell you, you guys know Julio, who spends his time going around the world, all the nations talk about, and as all of you know who do research tied to Latino populations, most of the nations do count race in their health surveys. Equal treatment and access to healthcare and health solutions for all Latinos. I think someone asked a question earlier about that, about a solution for, about shouldn't we look at the disparity, but should we also try to increase access for all Latinos? I think that is both. I think that we need to look at the inequality, and we can only look at the inequality once we're talking about not only a nationality inequality, but also a subgroup and also a class. When we look at socioeconomic factors that contribute to inequality. But also, secondly, yes, we are trying to improve health and health situations for all humans, but we can't ignore that and say, well, we're looking for all, so let's not look at the what's going on with each population. We have to look at the population in order to be able to get everyone to a level. Accurate treatment and remedies for different Latino population. And I think it just overall provides a more holistic approach to Latina health problems. Right? In order for us to actually look at issues that plague the Latina community, we can easily say, okay, let's generalize and let's look at, Mexicans and Puerto Ricans, and okay, we can diversify like that. But that's not the only thing that we should look at. I think that in addition to those points, we need to look at how those populations and how it's affecting racial groups within those Mexican populations, Puerto Rican populations, Colombian populations. And so on. I think that another point that I didn't write here, but something that I wrote from today, is I think the further diversification of the US population is going to lead us in that direction anyway. I personally think that the more and more diverse that the country becomes, with all the statistics and projections that by 2050 we'll have a more diverse country than any other country in the world, are going to lead us to have to look at people more holistically. So I'm challenging us to be ahead of the curve and say, okay, we know that that's coming, so let's not wait until 2050 or until whatever point to actually look at at different populations. Latino populations are just one group. One article that we contributed to earlier in the New York Times was looking at Arab populations and how they are also very concerned about their counting. So we're talking here about Latinidad, but the challenge is going to spread out to other sectors. And I think that one of the important things that I want to finish with is that de-emphasizing the importance of counting race is turning the clock backwards for us. So if we de-emphasize the importance of race and we continue to just say we just need to look at subgroups, and the subgroups are only national or ethnic origin, and we're not emphasizing race, I think we're turning the clock back to a time when that was an excuse for a lot of different injustices. So I think that I would like to leave us with that de-emphasizing race is not very important. It's actually detrimental to our cause. Thank you.
So good afternoon. It is with great pleasure that I join you here today. I bring you warm greetings from the second most beautiful island in America. We can't claim number one because it's your choice, either Puerto Rico or Hawaii. So, but we're the second, so we're okay with that. So actually, I'm very impressed by what I've seen and heard today. I'm inspired by our discussions, and I look forward to seeing where this all leads. I know that it requires more than one day and a small group of people to accomplish our goals in improving Hispanic health research and raising awareness of the issues and health ethics involved. So I want to call on Hispanic health researchers, educators, and stakeholders. We need a framework. We need a framework for our future scientists that provides a more accurate picture of the complexity of our Hispanic communities. And so we need to be open to the idea that it won't be just one framework. Actually, I should have changed this here. But the study of Latinos and the Hispanic EPIs, I think we've heard it mentioned today before several times, SOL, and the Hispanic EPIs led by Dr. Kyriakos Markides, a very dear friend of mine, and the extensive longitudinal historical studies from Dr. Dave Hayes Bautista, also a very dear friend of mine. Those are foundational studies that give us a place to start in identifying the framework, or frameworks that ultimately will help us define the heterogeneity of Hispanics. So there are two underlying issues that we must always bear in mind, and this is when addressing Hispanics. That the issues are that we have undocumented populations and we have uninsured populations. So the issues may confound or contribute to skewed data. And so that's something that I personally wanted to emphasize and bring to point, that those are two things that we should always keep in mind when gathering data from Hispanics. So I put them in scenarios, I thought about it and I said, well, there are probably just three large scenarios that I can talk about after looking at the topics or the titles of the discussions, the earlier discussions. And I said, well, the first one is going to be, from my point, is a disparate relationship. So what does this mean? So when we are looking at large data systems, we must be aware of for the potential for misrepresentation that could lead to a disparate relationship. So STARS, the Statistical Administrative Record System, is our big national database that includes census information. But if you do not have a Social Security number, or if you are not in the mainstream system, you will not be in this database. So the database may include some of the uninsured, but it may not include the undocumented. Dr. Hayes Bautista notes, I've been to several of his talks, and this is his quote: "The problems inherent in modern day US Census data, the chronic undercount of Latinos, difficulties in defining exactly who is a Latino, respondents' confusion over not just race versus national origin, but also self-identification as Hispanic already were evident in the censuses from 1950 to 1910. So I have been pretty lucky throughout my career as a researcher, starting in the year 2000, working with individuals like Greg Wilkerson, Dr. Lisa Franzini, and lately with Dr. Carl Leschbach and Dr. Kyriakos Markides. And I asked him, I consulted with him, and I asked him, can you give me an example? Because he works with large data sets. He was the former Texas demographer. Can you give me an example of, or can you talk to me a little bit about large data sets and the underrepresentation of Hispanics? And he actually, during his tenure as a Texas state demographer, was able to work with the CDC. And They were observing or making a report on the Lower Rio Grande Valley. Yes, I have to, I'm a blame. I did helicopter research, like many of us, starting as researchers in the valley. So we know the valley pretty well. And we know that it's actually one of the poorest parts of the country. So he was telling me that one time the CDC had come up with, but everything was corrected, just so y'all started not coming out in a negative tone here. It started coming out saying that, noting that that Brownsville, the Lower Rio Grande Valley, was very healthy. And he said, wait, how can that be? And so after obviously going back in and dissecting the data, yes, it was apparent that it wasn't. And so this is just a simple example of, and he quotes, working with the Texas Office of Rural and Community Affairs, we found that model data, like the Census Bureau's small area income and poverty estimates that are based on administrative records or general population surveys, underrepresent need for communities with large immigrant populations, a group that is missing from both types of data systems. So there's a big gap, and that was my take on one of the big scenarios. My next one is the numerator-denominator mismatch. So from the inception of the U.S. Census in 1790, Hispanics were not identified separately. For the most part, Hispanics were fit into the white category. It wasn't until 1930 that a category of Mexican was added to the census. It was dropped from the list for the following 4 censuses. And Hispanic origin was introduced on the 1970 census as a sample item, and it wasn't until 1980 that it was an actual complete census count. This alone speaks of our reality when interpreting and utilizing data. The Hispanic ethnicity is a true and an all-American construct based on our reality that the U.S. is a melting pot. As scientists, we find reasons to form groups, and that is to identify patterns. And as people, we form groups to self-identify or self-identity. Standing in front of you today, it's very important to me to be Hispanic. However, the moment I step outside of this country, I'm not Hispanic, I'm just an American. So in the 12 years of practicing medicine in Mexico, I've never once had a black man for a patient. He was a gringo to all of us. So because of the inherent flaws of data gathering, we can find it difficult to merge large data sets. We can miss populations, and we may overlook local or regional data that could be shared. My final point is privacy. When the Affordable Care Act, more have access to health care, but there is a greater distinction of those that are not legal, thus increasing lack of privacy and health disparity for disenfranchised populations. That is my quote. With the Affordable Care Act and the requirement for health insurance, the distinction between the insured and the uninsured is much more obvious. So to conclude, what does this all mean? So what does this all mean? In 2012, the New York Times published an article it's titled, "For Many Latinos, Racial Identity is More Culture Than Color." The main point of this article was that across the broad spectrum of people who identify themselves as Latino or Hispanics, most based their identity on cultural concepts and did not identify with any of the race categories that the census provides. And I think this is the professor from Harvard that you were mentioning, Dr. Mary C. Waters, is that her? A sociology professor at Harvard expounds, whenever you have people who can't find themselves in the question, it's a bad question. So I'm very dear friends with, and that's where my lucky part is. I talk every day. I have readily available the father of the Hispanic paradox, and that's Dr. Marquides. And I asked him before he took off to Greece again, because he's always at Greece. He's Greek. I said, Cocos, I need help. I'm giving this talk, and I know your database, it's a wave 9. It's one of the large ones, just like Souls. And just like, your history, like David Hayes Bautista, do you have anything to share with the people up there at CDC regarding large data sets? And this is literally what he said. He wrote it down in an official letterhead. He was so cute. And he signed it off, and he said, this is what I have to say. We have not yet understood the implications of rapidly growing numbers of older disabled Mexican Americans with respect to their dependence on their families. There is a need to systematically investigate how high rates of comorbidity, disability, and cognitive impairment, dementia, are influencing the quality of life of older Mexican American and other Hispanics, and what the consequences of these trends are for the quality of life of their families. We are facing a health crisis. We are facing health crises that have significant social impact. In order to respond to these effectively, I believe we need to be able to identify them. Thank you.
Thank you. I'm Rafael Sanchez Cárdenas from Dominican Republic. All we have here today is related with how can we change the discrimination and the bad situation of Hispanic in the United States. But I'm going to try to give you at a glance the practical situation of Dominican Republic in the last 3 years of the government of Dominican Republic. I took this picture from Mr. Cesar Fermin that I think is a good figure of what is happening, or at the same time, what we need to do. The Dominican Republic has a territory of 48,000 square kilometers, 9.5 million people in the population, and a GNP in 2014 of $70,000 million. The income per capita are $7,400. And we've been increasing our GNP year by year at a media of 5.4% year by year. The poverty rates have been changing from the 2000s. At that time, 32% of our population were in poverty situation. But then 2004, we had a crisis, a crack in the bank system that increased our poverty to 51%. That's something that Dominican Republic never have lived before. After that, the last year, the United Nations, by means of the Economic Commission for Latin America, CEPAL, established that the poverty rate at this moment is 33%. So we need to reduce 1 point more in poverty in order to return to the situation we had 16 years ago. The Gini index, as you can see, changed from 0.56 in 1205 to 0.48 last year. Before we get the government, we established that in the Dominican Republic we have three important problems related with the discrimination, the social discrimination that we have there. The first one is related with corruption. And the second one, education, and the third, the health situation of the population. As you can see, for years, all the government never take the money of the budget for education. In 2012, the budget for education represents 1.9%, and after we got the government, we increased, in accordance with the civil society, to 4% the budget for education. We doubled the money dedicated to education. And that is the point that is changing a lot our education, that as everybody have insist during this meeting, why Latinos do not speak Spanish. And that represents a real problem for health, but not only for her, but for job. That is an important thing to have health and to have education. If we don't know in a society that only speaks English, how can you take advantage of the opportunity that that society offers to a citizen? It's a real problem that we have in the United States. But where do you come from? From countries that speak Spanish, most of them, but at the same time, the situation of the education, that is the main tool. My president used to say that the new name, the education is the new name of freedom. And I can say after hearing all the people that have speak here, that it is true. In my society, the higher class do speak English. So this is not a problem for them. The problem is related with the poor population of our country. Because my son go to a bilingual college, so they don't have problem with that. But what about the most of the people of our countries? They don't have it. So here is the problem. Social justice. The rivals schooling in 2011 were 6 years. And in 2014, increased to 8 years, the median. The literacy rate, 40% in 2012, reduced to 6% last year. And we are expecting at this moment that perhaps finishing this year, the UNESCO is going to declare Dominican Republic free from illiteracy. That's because of the 4% in the budget for education. The matriculation in primary school that were 95% in 2012 increased to 99 last year. But here, an important problem of our education before we got the government. The number of class hours per day that children received were 3 hours in 2012. that means that we had to change this situation because each school, each building were divided in three. One in the morning, 3 hours, one in the afternoon, 3 hours, and one at night, 3 hours too. So how can those students receive a real education plan? Impossible in 3 hours. So we changed the curriculum and increased the number of schools in order to give our children 8 hours a day, not only for science, language, and history and social science, but sport and art. That is a way to increase the spiritual capacity of people. The number of classrooms were 29,000, and we increased it to 49,000 just in 3 years because of the budget. Daily classroom attendance were 3 hours, as I said, and we increased to 8 hours. But we have a diagnosis that established that children abandon the school and in other cases do not understand what they were receiving by the teachers. Why? For social reasons, not for intelligence capacity. They don't have a good food before going to school. They don't have shoes. They don't have book. They don't have uniform to go decent to the school. They don't have backpack. So if you think in people and not in the program that you receive in your desk, you have to change the situation. We need to put our children in school, in the classroom. So if they need food, we are going to give food, shoe, uniform, textbook, all they need in order to put them in condition to receive the education where they have the right to receive. That's what we did. That's why we are changing all the rates in education at this moment, just in 3 years because of budget. But at the same time, 5,000 teachers receive postgraduate grants in 3 years. The teacher salary increased from 26,000 pesos to 47,000 pesos in 2 years. But at the same time, those teachers who have a master or a PhD receive another incentive. One of our most important actions, despite the modification of the curriculum and the support to children and expand the time in school, is the international program grant that we are supporting nationally. This permits us, for the first time, to send students to Tuskegee University, where I am signing an agreement recently. But we have more than 10 agreements with U.S. university. We are sending more than 2,500 students to make master and PhD program out of Dominican Republic. So I fly all over the world looking for agreement with university and institute in order to modify the quality of our human resources for teaching and to make science actions. Tuskegee is very important and well related with the act we are having today. Is, let's say, a black university that I know when I was studying medicine, hear about the syphilis program there, but nothing more. Now I can speak a lot about this university and the importance for Dominican Republic. We are diversifying the university where we are sending students and teachers just to receive in Dominican Republic, not one version of education or one version of science. So we send a student to Korea, to Japan, to Singapore, to Russia, to UK, to France, to Spain. Spain was the first country where we sent a student. Of course, they speak Spanish. But we discovered in this process that bilingual, as you have demonstrated today, is a necessity for the world of the future. So we open at the same time in the Dominican Republic 5 immersion programs in language. English, where every day, every year, we graduate 10,000 students in English in an intensive course. German, French, Portuguese, Russian, and now we are beginning with Mandarin, because China is very important today. One of the most important programs that we are developing is the so-called surprise visit of the president. It's something that I'm sure you'll never hear about. For me, it's an innovation. I've been invited to this visit, and it's a focus policy in the poor people of the Dominican Republic, essentially in the rural sector where live the poorest of all. This is the picture of the president talking with the farmer, just in the farm, with 4 persons, as you can see, no more. Only a bodyguard. It's a focal policy in 3 dimensions: credit, technical assistance, and cooperative and association promotion. Why these policies? Credit is a right all over the world today. Everybody cannot depend on the action of the government. So it is recognized the importance of the entrepreneurship action to promote the initiative, the private initiative of each citizen, and to obtain all the benefits that his image and action can provide to a family. So we increased the credit from 11% in 1991 and reduced during the financial crisis to 3%. But now, last year, we increased it to 20%. Perhaps you don't understand what does it mean about the social disparity that it represents. The financial crisis destroyed almost all the rural sector and the urban sector. We increased from 33% the poverty to 51%, as I told you. With this program, we give credit, but at the same time, before the president get the farm, the technicians go there, economists, farmers, social workers, in order to discuss with the community what they need, and at the same time to establish, what they know to do, what they have there. And then come the president in order to discuss directly, as you can see, in a meeting where the president is sitting down in front of people in a plastic chair, just at the matter of the people, and began one of the marvelous discussions that I have ever heard and see in my life. Everybody talking, everybody giving his opinion. And he trying with some support to give the answer they are needing. But with a condition. A farmer in the Dominican Republic represents more than 90% are of from 2 to 10 acres. How can they produce so much product with such a farm? Impossible. They need association. And the president said, okay, I have the money for you, but you have to increase the number of this association, the double. And usually 2 weeks after, they are prepared to receive the money. And there's technical support about that. Current state. Well, at this moment, as you see, we reduced 11% in 4 years the poverty of the Dominican Republic. And we have targeted initiative on the way to deepen these policies in order to keep on reducing poverty in the Dominican Republic, but at the same time to reinforce the access to education. We have 99% of our children at school. If we keep the children at school in better condition, because Dominicans are intelligent, of course, I think in 5-10 years we are going to have a new generation of educated people that are going to continue what I was doing here. This is the reason why the president said education is the new name of freedom. And I think it is true. What we have learned, that a combination of universal public policies, like a macroeconomy stabilization, pay attention to this in Latin America. If we reduce 11% the poverty, but we miss the macroeconomic stabilization, we are going to come back again. And that's something that you usually see in Latin America. But at the same time, we need sustainable social protection. At this moment, 85% of the population of the Dominican Republic have a health care insurance. And we think that in 2 years, 100% of them will receive the ticket, the carnet for the social protection. Let me remark that the cooperative relevance of the association in our country. It is the social capital that can change a tradition in the distribution of the land, but at the same time that reduce one of the genetic competitiveness of today. To know how to work as a team. Even research, we need team today in order to improve our knowledge. That's what we are doing right now. What is missing? I think that based in public policies on research outcomes, it is a very important action in order to give light to our problem. It is very important. That's why we are implementing the international program for postgraduate courses, in order to give support with a critical mass to our process. We have to be more efficient in the strategic planning. It is common that We see the next step, but we don't think in Latin America about the future. There's an only way to see the future, strategy plan, to give a large goal to our planification. Thank you.
Okay, yes. I have one slide. And if everybody make sure you have your green, yellow dots ready. So I want to bring it all together for you, and this must be a very familiar framework for Dr. Liebert. We were quite honored to publish this special issue on health equity. So if we look at this as Hispanic health equity, then where does it leave us? Science is for naught if we don't translate it into policy. I'm glad that the Vice Minister ended with policy, because that's not a lot of what was covered today. But yet it is really policy that will bring equity. Not all the science we have. The application of policy, in turn, has to inform science. Now, science also will not influence practice if the science doesn't lead to risk reduction. We've heard a lot about risk factor analysis, but if that doesn't work, if that doesn't lead to risk reduction, then practice can never be good service. At the same time, practice must inform science so that we don't do science for science's sake, not the nice to do things, but the must to do gaps. And that comes from a practice-based, a frontline driven, a community participatory driven gap analysis. And so before we even can start implementing practice, implementing policy and monitoring practice, we must deal with the issue of equity. Science can never equal health without any of those three. And so I bring this together for you and looking at the priorities that we have, asking you to help us identify, prioritize those major issues for us, but keep in mind this framework, the three foundations of public health. Thank you. And so we'll take some questions now while you're going through this exercise. So questions for any of our speakers? The priorities are on the wall, and I'll be adding a few more based on this panel's exercise. Yes, please.
Hi, good afternoon. My name is Tipatli Mendoza, and I have a question for the three panelists. I think throughout the whole day we discussed about race, but we haven't touched on racism, which I think is the big elephant in the room that we never really talk about. And I was wondering from your perspective, because I know from the three communities that they're both representative, those are it's a big issue that impacts the population health in all three communities. And so I want to know what is being done or how you're addressing that in the work that you're doing.
Any of the panels? Gisnet.
Thank you. That's a very good question, actually. So racism is obviously a huge problem in our community. As many people know, the Afro-Latino community suffers from kind of double, triple racism from within the general American population. So being citizens, or like I'm a citizen here, I'm a Black citizen here, I'm an Afro-Latino citizen here, but also I suffer racism from the quote-unquote American United States side, but also suffer from internal Colombian community, racism from there. So I think that the reason why we're not discussing racism as much is because we haven't discussed race as much as an important point, which is why I think that it's one of the points that I think that everyone tries to highlight. But there are many studies that show that racism is very directly connected to problems such as depression, For example, there's a research recently by McGill University that showed that racism is tied a lot to depression amongst Black Latino young males, and then therefore leads to suicide rates and all other things that depression links to, all stemming from racism. The same thing with the research that I was quoting from hypertension. The hypertension study shows that there's a link in hypertension and racism. So I think that's why I think that emphasizing race is important, because I think looking, and not only looking at it by nationality, but also trying to emphasize the fact that race plays a large factor into certain health conditions in Afro-Latino communities.
Any other perspectives on racism? A question. Oh, a comment, okay.
From the previous speakers combining, which I think is significant for this, for your point. The issue, of course, of lack of proper communication in the collection of data, how skewed the data is. And I was just talking to Dr. Rodriguez saying, okay, so example, the patient comes in, it says, tengo un dolor muy grande, I have a terrible pain. And the doctor says, well, where does it hurt? And he says, en todas las entrañas. Now, enter that in Google Translate and see what you get. And the reason why I bring this up is because that is exactly what he was saying about the skew in the data. And so if you go to 5 different countries along the Latin American side, you get a different answer on that one. Not only that, but entrañas is everything, and then if it's a local person, it might say one entraña, which is one internal organ. So it is critical, and I was talking to my partner here, that we find a way, and I don't know how it's going to take a long time, to normalize, key question here, normalize the way that the question asked, and normalize what is exactly that we're seeking from those patients, because the majority of them do not know what they've been asked. And I know that. Say in Guatemala, how much does it cost? Dos pico. It doesn't mean the same in the Dominican Republic. And you look it up if you want.
Thank you. Other questions or comments?
I just want to finish a point that I forgot, because you said, what are we doing? One of the things that our organization, the Afro-Latina Forum, is doing, we're conducting a survey on kind of looking at a specific segment of the population in New York and how they identify by race category, and then looking at how that affects other issues. So I just didn't finish to say what we're doing there. Sorry.
Thank you. Yes.
Hi, I'm Christina, and I'm a junior research scientist at CDC, like very new, brand new, still learning. So I really enjoyed the conversations and the presentations from the previous panels, and this picture is one of my favorite ones. Like, as a new researcher, I was thinking about implications for practice and policy, and I wanted to ask you guys, given the conversations that you presented today, what is a tip or a recommendation that you would say a young researcher when thinking about doing studies for populations, to make sure that we might not fall into the same pitfalls that previous research have gone before, even though they do try to, look at the discriminations or the disparities that are existing in our varied populations. Do you have kind of like think of this when you develop your research questions to ensure that your research or the findings of your research might not have some unintended consequences, that instead of addressing the disparity that you were looking for, you're actually highlighting it? Because I felt like there was that sense of theme overall in your conversation, that although people do try to address the disparities and look at them, there are unintended consequences of not really doing the correct thing. Thank you.
Thank you so much for the question, and actually that fits right into the mission of HSHPS. There is, of course, if you're looking at NIH or whatever agency you're looking for to apply for grants, there is a very important section in your 12-pager, and that section is innovation. So it is in the innovation section where we show how different you are than all the work that has already been done. And so you're right, you could use this template and have 6 innovations right there. So where is the innovation in translation or in application or in gap analysis or risk reduction? Today, and actually we're hoping to make this and publish this nationally, today you have a set of priorities, a set of questions, a set of gaps that we each have contributed that have kernels of of innovation. The work that Dr. Flores shared, for example, to look at LEP very differently. And so you could go through each of those speakers and find those kernels. Dr. Perez Estable talked about the 4 key questions that he's focusing on. But taking those questions and not doing the same old. I always tell my students and junior researchers, don't do the Me Too research. That might let you on somebody's coattail, but it won't let you grow into an independent researcher. Or in fact, currently now an interdependent researcher to become part of a transdisciplinary team. But it's the innovation section. And actually the second most important section to me, and that's often ignored by many scientists, is the public health relevance section. So 3 sentences to me that should be an up or down to fund the grant, but yet it's not being seen as peers by the peer reviewers. But those are the 2 sections to me that are critical.
Can I add something very quickly to that?
Yes, sure.
I think another point, one of the issues that we have, especially in the Afro-Latino community, of finding out statistics, because there are no statistics, and it's very difficult. There are very minimal statistics to find that out. So what we always try to challenge people to do is to create the norm for developing that statistic, right? So it's difficult for us to, so I can't pull out like 55 research examples of Afro-Latino and how race affects health, because there just aren't those, they just don't exist. So someone has to be, so I think that's where the point of innovation comes, where the Dr. Litchfield is mentioning. Someone has to be the person who start that and to create a norm. And I think there are people who are already doing that research. They're starting to, but I think as we parse it out more and as we look at how race affects or how different questions affect. So I would say that you should look at race. Well, obviously I'm going to tell you should look at race, but you should look at race. And not, I think like Dr. Litchfield said, now saying, well, people in the past haven't done it, therefore it's not an important category, which is usually what happens. Someone says, well, it wasn't done before, therefore we don't need to do it now. I think that sometimes it's good to create a new norm and say, well, we do need to actually look at race when we count the Latino population, and what effect does that have on health access and health education. So I think creating the norm is a very important thing. That's why I'm glad that we're in this panel, because creating that new norm to have more numbers to look at. The fact that there is no data doesn't mean that there isn't any data. It just means we haven't gathered data.
We'll take one more question and then we'll
It's
break.
actually a comment, follow and up for your question. I work with the National Alliance for Hispanic Health, and we work with a network of community-based organizations. Work with those agencies, okay?
Yeah.
Do community participatory research. They already have the language skill, the culture skills, but don't just go do the research and then leave, okay? Bring back the results.
Yeah.
So, and then that way you'll get, the best of both worlds.
Excellent. What a good note to end. Priorities go forward.